Hey everyone, today we're going to talk about an animated exploration of chronic fibrosing interstitial lung disease, from diagnosis to management in the era of antifibrotic therapy. I'm Cedric Jamie Rutland. I'm an MD that practices in Southern California at West Coast Lung. I spend a lot of my time on immunology as it pertains to the lung. I have a large interstitial lung disease and idiopathic pulmonary fibrosis clinic, and today I want to talk to you about defining, diagnosing, and recognizing chronic fibrosing interstitial lung disease. So as always, the first question is, what is interstitial lung disease, right? We get this question a lot. And I think it's extremely important to define the secondary pulmonary lobule, which is the basic unit of function of the lung. When you look at this image, what you can see is the secondary pulmonary lobule, and you'll see the connective tissue, which basically outlines what's called the interlobular septa. And then the same connective tissue also outlines the bronchiole, the pulmonary artery, and the pulmonary veins there. And when you're looking at this connective tissue that surrounds those vessels and those airways, it also surrounds the alveoli. And this is what the interstitium is. And so interstitial lung disease refers to a heterogeneous collection of over 100, 150 distinct lung disorders. Typically, the presentation of interstitial lung disease is very nonspecific, and it includes dyspnea on exertion, cough, fatigue, diffuse bilateral soft tissue infiltrates on chest imaging, and then when you look at pulmonary function testing, that is the amount of air that we're measuring going in and out of the lung, you can see that your functional vital capacity is reduced, as well as your diffusing capacity also reduced, but your FEV1 to FVC ratio is typically normal. So that's what interstitial lung disease actually is. When you think about what is a chronic fibrosing interstitial lung disease, we have to come to this understanding. Once the interstitial lung disease starts its pathophysiology, that is, the cellular infiltrate begins, the end product of this is a fibrosing interstitial lung disease, right? So some of these interstitial lung diseases will stay cellular forever, but some are going to develop this progressive fibrosing phenotype, and you're going to see worsening fibrotic changes on a high-resolution CT. You're going to see decline in lung function over time due to these fibrotic changes, and then these patients are always going to have worsening symptoms, a terrible quality of life, and all of these things are going to increase their mortality, so you're going to get early mortality in these patients. IPF, idiopathic pulmonary fibrosis, is generally recognized as the archetypal progressive fibrosing interstitial lung disease, right? This is kind of like the granddaddy of them all, IPF. However, a progressive fibrosing phenotype does develop in other interstitial lung diseases, and it's important to understand that this progressive fibrosing phenotype can take place in nonspecific interstitial pneumonia, idiopathic nonspecific interstitial pneumonia, hypersensitivity pneumonitis, interstitial lung diseases associated with an autoimmune disorder like rheumatoid arthritis, and scleroderma interstitial lung disease. We know that when you look at scleroderma, 67% of patients with scleroderma have lung findings on chest CT. Recent evidence, when you're looking at chronic fibrosing interstitial lung diseases, suggests that anywhere from 13 to 40% of patients with individual interstitial lung diseases are estimated to develop a progressive fibrosing phenotype. Between 25 and 50% of patients with a chronic fibrosing interstitial lung disease do not receive drug therapy. So this begs the question, right? Does drug therapy actually help people that have fibrosis of any kind, whether it's IPF or whether it's fibrosis that's related to other connective tissue diseases or other interstitial lung diseases? So when you're looking at nonspecific interstitial pneumonias, we know that 14 to 35% of them do develop a fibrosing type of phenotype. When you're looking at connective tissue disease, interstitial lung diseases, we're talking about systemic sclerosis, right? Scleroderma, rheumatoid arthritis, polymyositis and dermatomyositis, Sjogren's syndrome, lupus, MCTD or mixed connective tissue disease, and then antisynthetase syndromes. There are unclassifiable interstitial lung diseases. Unclassifiable by definition means that there are certain things during the workup that weren't done. Maybe a bronchoscopy wasn't done. Maybe no biopsy was done. Maybe there's overlapping histology if a biopsy is done, meaning you're seeing two different types of characteristics. Maybe you have a discrepancy between imaging, clinical, and histological features. You don't really know, so you can't really classify it. That's unclassifiable. And the reason we're defining these groups is because this is how we're going to study interstitial lung diseases in the future. We want to be able to separate out groups. Hypersensitivity pneumonitis, we know that it takes place mostly in the upper lobes of the lung. They have a delayed type 3 or 4 allergic type of reaction, and there's environmental exposures. And then you have the granddaddy of them all, which is idiopathic pulmonary fibrosis, which we all know how to define, and that's easy. When you look at the immunology or pathophysiology of fibrosing interstitial lung disease, there are mechanisms that are known to be involved in the pathogenesis and progression of fibrosing interstitial lung diseases. So fully understanding the different groups, nonspecific interstitial pneumonias, unclassifiable ILD, hypersensitivity pneumonitis, idiopathic pulmonary fibrosis, the granddaddy, and CTD-ILD. Once we've established these 5 groups, you want to understand if the mechanism and pathogenesis of progressing fibrosis of interstitial lung disease is the same. So let's go into this animation and take a closer look. Several mechanisms are known to be involved in the pathogenesis and progression of all fibrosing interstitial lung diseases. All interstitial lung diseases are believed to be triggered by repetitive chronic epithelial or vascular injuries, or by granulomatous inflammation, which leads to cell destruction, and in the case of fibrotic disease, to unregulated repair. Fibroblasts, the main effector cells in fibrosing interstitial lung diseases, are recruited from resident fibroblasts, circulating fibrocytes, and epithelial cells and fibrocytes undergoing epithelial mesenchymal transition. This recruitment is brought on by the release of certain profibrotic mediators. But once they're released by this damaged epithelium and endothelium, leukocytes, white blood cells, are recruited. Mononuclear cells and T cells release profibrotic mediators that further promote fibroblast activation. And these activated fibroblasts transition to what are called myofibroblasts via fibroblast-myofibroblast transition, which releases excessive amounts of extracellular matrix. This results in increased tissue stiffness, which further stimulates fibroblast activation, leading to self-sustaining fibrosis. When are you going to suspect interstitial lung disease? Almost any time someone has shortness of breath, chronic cough with basilar crackles on their physical exam. It's really important to listen to that. It's one of the things that I teach to my residents and fellows. You want to examine the hands and joints for evidence of autoimmune disease and clubbing. You want to order pulmonary function testing and really pay attention to that restrictive pattern. You definitely want to get a chest radiograph. And you want to perform some kind of hallway walk test. That is, increase their heart rate to the point that their oxygen saturation may reduce. If any of these suggest possible pathology, you want to get a high-res chest CT. Once I have a question of if IPF is present or any interstitial lung disease is present, I'm going to get a high-resolution chest CT and I check serologies right away. And if I get a specific diagnosis, I'm done, I'm good. I'll work with the rheumatologist. If not, I really got to pay attention and look at this HRCT and fully understand, is this probable UIP on HRCT, indeterminate UIP, or are there other findings like ground glass opacities that are suggesting an alternative diagnosis? If it's UIP, I might get together a group of friends, rheumatologists, allergists, other pulmonologists, and I may talk about this, right? We call that an MDD, right? A multidisciplinary discussion. And then decide, do I need to do a bronch? Do I need to do a biopsy, right? And if I do, then I can get a diagnosis. If I don't, how am I going to treat this? Is this idiopathic pulmonary fibrosis? Is this not idiopathic pulmonary fibrosis? And if it's not idiopathic pulmonary fibrosis, what is it? So when you're looking at the role of high-resolution chest CT in diagnosing UIP, we know these guidelines. We knew these in medical school, right? Subpleural basilar predominant fibrosis, increased reticulations, honeycombing, little cysts stacked on top of each other, and then the absence of features that would suggest an alternative diagnosis. So you're really not going to have a lot of ground glass opacity. When you're thinking about nonspecific interstitial pneumonia and how you diagnose that on HRCT, again, you're going to get that basal predominance. You're going to get peribronchial vascular and subpleural sparing. So you're not going to see disease in those areas. You're going to get a confluent pattern with volume loss, but you're going to see a lot of ground glass opacity and reticular findings. You're also going to see what's called traction bronchiectasis with consolidation. Traction bronchiectasis, if you can imagine, it's almost like you have scarring on the outside of the bronchiole that doesn't allow it its elasticity anymore. It's not going to close. It's just going to stay open. You might see a little bit of honeycombing, but again, this is non-specific interstitial pneumonia. It's almost difficult, but it makes it easy because it doesn't really have specific features. When you look at hypersensitivity pneumonitis, again, you're going to get upper lung predominance. If it's chronic, it can be mid or lower lung predominance, but you also are going to see centrilobular nodules and mosaic attenuation. When you think of mosaic attenuation, that means you're going to see areas of white and areas of black on a chest CT. And when you look at it even further, you can see some centrilobular nodules. Now, looking at the CTs here, you can see in all these CTs, there's a hint of mosaic attenuation. There's definitely a little bit of traction bronchiectasis here. There's also some centrilobular nodules. Those are very, very subtle, especially in that bottom CT, right? When you look at that bottom CT there, the centrilobular nodules are very, very subtle. So you really want to get in the habit of looking at this, right? And perhaps as a pulmonologist, even as a rheumatologist, you don't want to just rely on radiology. You want to develop an eye when you're seeing these patients. Here's the thing that's important. When you're looking at the functional vital capacity, when you're looking at your FVC across many different studies, particularly the InBuild and the InPulsus, right? Patients with IPF and patients with chronic fibrosing interstitial lung disease, their FVC declines in a similar way. What does that tell you? That tells you that it really doesn't matter the cause or the diagnosis that's leading to fibrosis. Fibrosis is fibrosis, and that FVC decline is that FVC decline. And when you look at it even closely, when we separate out these 5 groups that we talked about, HP, autoimmune ILDs, idiopathic NSIP, unclassifiable, idiopathic interstitial pneumonia, and other ILDs, the FVC decline is similar across all the subgroups, especially when you look at the fibrosing part. When we're recognizing progressive interstitial lung disease, we don't know what their disease course is going to be unless we see patients pretty frequently. I tend to see my interstitial lung disease patients every month because I want to know, are you going to progress fast or slow? We don't know, right? You have this onset of symptoms. If you have an exacerbation, we know that reduces your survival in the long term. We know that that's going to lead to an increased mortality. We don't really want those things, right? Because of these micro injuries that take place, you get this downtrending FVC and this downtrending disease course. The problem with progression of interstitial lung disease is there's no single criteria for defining that progression. There are many different ways to define it. When you look at these different studies, the Pirfenidone study defined it as 5% FVC decline or greater, significant symptomatic worsening. The Relief study looked at annualized decline of FVC greater than or equal to 5% over a course of 6 to 24 months. When you look at other types of studies, they take a combination of things, whether it's that FVC decline in combination with the radiographic findings that you see. And I think all of that is important. The key is to have close patient monitoring. That's the key because you want to understand if your patient is becoming progressive. How does chronic fibrosing interstitial lung disease progress? When you think about interstitial lung disease, the way that I like to think about it, you have this chronic inflammation that's taking place in the alveoli, in the interstitium. It's going to start with the cellular infiltrate. It always does. But you have no idea when it's going to completely transition to fibrosis. You just don't know. When you look at IPF, yeah, it's mostly fibrosis, right? When you look at progressive RA-ILD, it might be mostly cellular for a while and then transition to fibrosis. When you look at another progressive RA-ILD, it may fibrose earlier than expected. When you look at HP, you get inflammatory findings, you get fibrotic findings. I used BAL to help me define that a little bit. And again, it's all subjective here, but the point is that immunomodulating therapies like prednisone, like mycophenolate, they're gonna have an effect when you have this cellular inflammation. Antifibrotic therapies are gonna have an effect when you have fibrosis, or perhaps these antifibrotic medications may prevent fibrosis. We don't really know. All we know is that this is what's presumed. When you have inflammation, immunomodulating therapy. When you have fibrosis, antifibrotic therapy. So when you look at the impact and burden of chronic fibrosing interstitial lung disease, we really want to get a sense of understanding disease progression because this is what affects quality of life. Not only that, but it also increases healthcare resource use. That is, you're going to get CTs, you're going to get started on therapy, you're going to go into the hospital with exacerbations. So when you look at the estimated cost, it's 1.8 times more than the non-progressive stage of fibrosing ILD, almost twice as much. Chronic fibrosing interstitial lung disease negatively impacts not only the patients, but also their unpaid caregivers' quality of life. I know this. My grandfather had an interstitial lung disease, and so it affects their quality of life. Up to 46% of these patients suffer fatigue. So you got to think about how that's going to affect their partner or their family member's life, because it does. The most common comorbidities when you think about chronic fibrosing interstitial lung disease include pulmonary infection in 30%, depression in 27%, that's important, osteoporosis in 20%, and pulmonary hypertension. 71% of chronic fibrosing interstitial lung disease patients are retired, and almost 27% retired early because of their illness. So you got to think about that, right? This is the time when patients want to enjoy their life. They want to retire. 48% of chronic fibrosing interstitial lung disease patients had total permanent disability compared with 20% of the non-slow progressing fibrosing ILD, right? So 50% of these patients are having a disability now. 20% of patients required support from a paid caregiver for a duration of 8 hours a week. Almost 61% of these patients needed support from an unpaid caregiver, such as their spouse, their family member, their neighbor, for almost 30 hours a week. So I really think it's important here to hear from a patient. We got to hear from their caregiver. And that patient and that caregiver who you're going to hear from right now, their experience is important.
My symptoms started when I had a flu and a cold. So I went to see the doctor. They treated me as a regular flu. But after 2 weeks, my coughing didn't go away. So I went back to the doctor. My doctor gave me antibiotics for 2 weeks. Coughing didn't go away either. So they decided to take x-ray, my chest. They found that the chest has a little bit something there. Then he recommended me to see the specialist. The specialist did all the tests. Okay, did the called the scopic test, and then also did biopsy test. They found I had a little bit fibrosis.
When we first were seeing a doctor, they instantly were like, oh, you have fibrosis on your CT scans, you only have 2 to 5 years to live. You would never even fathom how to take that for your father or for anybody for that matter. So it was just such a quick diagnosis that it didn't seem real, and it didn't seem like they were giving us enough information or preparation or even education on the matter. It was almost as if they left it up to us to figure out what we wanted to do about it. It wasn't until, I would say, almost a year later when we moved to California and saw another specialist that he took more time to understand his whole lifestyle and maybe some more previous conditions before automatically saying this is what it is and this is how much time you have to live. So that in itself makes a huge difference in how you communicate to people that don't really understand the medical terms or the disease. He is just coughing more than an average person would, and that's something I think that's hard for a body to take throughout the day. I mean, he's obviously pretty used to it, but we hear it, so it is more than an average person would cough, and he gets tired pretty easily. And when he was off his meds and coughing more frequently, he had low energy and was unable to even act like he was around or alive, really, because he was just tired all the time. I think the coughing really takes a lot out of a person in general, so I think the consistent coughing is what really makes this disease or this treatment kind of like difficult for him. I think losing weight is also another thing. The fact that obviously most people want to lose weight, but for him it was concerning, especially for people that are entering like the older ages, getting more in the seniors. Losing weight is always a sign of like worse illnesses to come. So I think that was concerning. So he was always trying to eat, but then he lost his appetite because of I don't know if maybe the medication or just his coughing and things like that. I would say we live together, so that's been very convenient for me to step in as a caregiver. So basically, in the beginning, I was really anxious about the prognosis because they said that it was pulmonary fibrosis. So they were like, oh, he only has like 2 to 5 years to live. And it was like instant panic. And I was stressing out, and every little cough, every little, he would choke a little bit, I would freak out and be there and then figure out what's going on or Google symptoms or if I should call a doctor or the ambulance. And then as I attended more of his appointments and talked to the doctors myself, got to know Dr. Rutland, got more details, I could step back more in the caregiving because it was like a maintenance thing now versus a like saving his life kind of feeling. I think it's just having one more thing on my plate to make sure that he's taking his medications. It's something that's just always there because it is one more factor into his health and on top of his aging. So in general, I would say it has affected me in terms of just wanting to care for my father and just being on top of his treatments and making sure that he's getting the care that he needs.
So as you just heard, chronic fibrosing interstitial lung disease takes a significant toll on both patients and their caregivers. We got to talk about how we manage these patients. This is extremely important. Again, I'm a guy that likes to be ahead of the game. So as we move into that, and you don't always have to prescribe a pharmacotherapy, you can put patients on oxygen, and it does help them feel a little bit better. You can use, at least inpatient-wise, invasive ventilation. You want to schedule them for pulmonary rehabilitation. It helps them deal with what they got. It's very important. You also want to make certain that you're protecting their lung, right? In this age of COVID, in the COVID world, you want to make sure that a vaccination is happening, whether it's influenza, whether it's SARS-CoV-2, because you don't want any excuse for their lung to become inflamed because they don't have that reserve anymore. If they smoke, you want them to quit smoking. And there is lung transplantation. That is an option. So when you think about pharmacologic therapy, you want to think about immunosuppressive therapy because it is effective early before fibrosis. It really is. And the disease course is really effective is in idiopathic interstitial pneumonias, non-IPF idiopathic interstitial pneumonias, CTD-ILD, and hypersensitivity pneumonitis, along with interstitial pneumonias with autoimmune features, which is essentially a CTD-ILD. So you want to be able to have an impact, and immunosuppressive therapy can work especially early on. Once fibrosis is present, immunosuppressive therapy may not be as effective, or it's had its maximal effect and it's time to not only continue immunosuppressive therapy, but to add on an antifibrotic. These are the things that I do. Antifibrotic therapy, like pirfenidone, which was granted breakthrough therapy designation, and nintedanib, which is now approved, may ameliorate the decline in lung function in non-IPF fibrosing ILDs. I use it and I see this, right? When you see a UIP pattern, they especially work. So when you look at immunosuppressive therapy, what medicines do we use to immunomodulate patients that have this cellular infiltrate of their interstitial lung disease that's not quite fibrotic? Well, we use mycophenolate mofetil and or azathioprine for chronic hypersensitivity pneumonitis because when patients are on these medicines, it does preserve their FVC. More patients are going to have a normal FVC or not decline as much over the course of a span of a year than patients who are off of these medicines. So we do use these medicines, and this has been proven in medical literature, mycophenolate mofetil and azathioprine. Antifibrotic therapies for chronic fibrosing interstitial lung diseases include the same antifibrotic therapies that we use for IPF. We're talking nintedanib and we're talking pirfenidone. So when you're looking at these two different therapies, know that they're both effective in chronic fibrosing interstitial lung disease. Let's look at a particular trial, the INBUILD trial. The INBUILD trial is a double-blind trial, and we wanted to look at how nintedanib was going to have an effect on patients with chronic fibrosing interstitial lung disease. We wanted to know what was their FVC decline. We wanted to know the eligibility criteria here, which is a diagnosed interstitial lung disease other than IPF, which they got naturally, by the way. You had to have features of diffuse fibrosing lung disease. So you had to have reticular abnormalities with traction bronchiectasis. We went over that, with or without honeycombing, of greater than 10% of an extent on an HRCT, less than or equal to 12 months prior to screening, confirmed by other reviewers. They wanted these patients to have an FVC above 45% predicted and a DLCO in between 30 and 80% predicted. So when you look at the patients, we had 330 patients in the nintedanib group, 330 patients in the placebo group. And again, the 5 groups we were looking at were hypersensitivity pneumonitis, autoimmune interstitial lung diseases, idiopathic nonspecific interstitial pneumonias, unclassifiable idiopathic interstitial pneumonias, and other ILDs. Unclassifiable. I know that this group is confusing, but when you look at it, it's people who didn't allow us to work them up completely, or they had a lot of features of many different illnesses, so you couldn't really classify it. So when you look at the FVC decline, and you look at the annual rate of decline in FVC over 52 weeks, you can see that the placebo patients not on therapy, had a greater decline in FVC. In the overall population, it was almost 190 cc decline in FVC. When you look at patients with a UIP-like fibrotic pattern, it was even greater, over 200 cc's, 211 cc's reduction in FVC. When you compare it to patients on nintedanib, they had less of an FVC decline. When you look at this in the long form and you're looking at this data over the course of 52 weeks, you can see that the placebo group had a greater rate of FVC decline. And you can see that very nicely here. Even more so, if they had a UIP-like finding, their FVC declined even further. And that's something that's important. But look if you're on nintedanib and you had a UIP-like finding. If you're on nintedanib and you had a UIP-like finding, the drug was great, whether you had a UIP-like finding or not, or in the overall population. I think that that's a great point to be made here. You're looking at the annual rate of FVC decline over 52 weeks. First of all the groups, the overall population, the UIP-like fibrotic pattern, and the other fibrotic patterns, they all favor nintedanib. But the way that they did this is they broke down the efficacy endpoint of FVC into 3 categories, as I just mentioned. All patients, right, overall population, UIP-like only, and all other UIP fibrotic patterns. Now, what they show is that all 3 groups favor nintedanib. Patients did better in each group if they were on nintedanib, but no one group by itself did any better than the other. They were not, I repeat, not statistically significant if you run the analysis against each group to each other. You can see that p-value of 0.23. So they were not statistically significant. Therefore, it doesn't matter if they were UIP or non-UIP, there was no difference in the benefit. In other words, the drug is just as effective if you have UIP than if you don't have classic UIP, but you have fibrotic findings. That's an important point to make. When you look at the adverse events in the overall population, the adverse events here, you're gonna see in the placebo group and the nintedanib group, they were pretty much close to one another. Adverse events leading to permanent discontinuation of study drug, again, yes, that's gonna be different. You can see that there are twice as many people here in the nintedanib group that had that. But other severe adverse events, they were very similar. I mean, look at the placebo and the nintedanib groups. You can see that. The fatalities were much greater in the placebo. Serious adverse events were similar. Severe adverse events were greater in the placebo. I think it's important. When you look at our pirfenidone phase 2 method, study design, and patient population, here's the inclusion criteria here. You've got patients that are greater than or equal to 18 to 85 years old. They have a diagnosis of a fibrosing undifferentiated interstitial lung disease. Their FVC was greater than or equal to 45%. Their DLCO was greater than or equal to 30%. They had greater than 10% on HRCT within the previous 12 months, and they had progressive disease within the previous 6 months. Our primary endpoint results here, predicted FVC change from baseline to week 24 measured by home spirometry. You can tell in the pirfenidone group, we had less of a decline compared to the placebo group. So pirfenidone and nintedanib are both effective, right? Secondary endpoints, FVC change from baseline to week 24. You can see it here, again, more patients declined not on therapy. It's very important to understand that when you're not on an antifibrotic, you're going to decline from a chronic fibrosing interstitial lung disease standpoint more than if you were on an antifibrotic. When you look at the safety results, right, and the summary of the adverse events, again, you can see that the drug is pretty safe. There's a few more events in that pirfenidone group, especially treatment-related events. You're going to see that. Severe events in both groups are pretty similar. So when you're treating these chronic fibrosing interstitial lung disease patients today, you want to take a look at these patients. You want to diagnose them with their interstitial lung disease, easy. You may want to take a multidisciplinary approach. You may want to talk to a rheumatologist if you're a pulmonologist to rule out other types of rheumatologic conditions because there are different therapies that are offered. Or if you determine it's IPF, you want to discuss the initiation of antifibrotic medication. Maybe you want to start thinking about lung transplant if the patient meets that criteria. If they're not IPF, ILD, you still want to know, do they demonstrate fibrotic type of findings? Is there traction bronchiectasis? Is there slight honeycombing in the base, right? You want to know this because you know now that if we put them on an antifibrotic therapy, it's going to be effective. Do they have CTD-ILD? Do we consider immunosuppression? Do they have HP? Let's do an HP panel. Let's consider antigen avoidance. Do they live in an older house that has a chimney and pigeons still defecate in that chimney, which leads to that antigen and leads to that inflammation and HP? Again, you want to have these discussions about initiating therapy because ultimately you want to reduce time to acute exacerbation, with nintedanib does. You want to save their lung function over the course of time, which both pirfenidone and nintedanib do. These are the types of things that you want to do. When you look at this condition, chronic fibrosing interstitial lung disease, which does require imagination and visualizing what's going on in the lung, understanding which mediators are being secreted and how they're interacting with the airway cells, how they're interacting with fibroblasts, what this cytokine or chemokine does. I know it's important to imagine this, but you have to understand that this process of immunology continues to fibrosis. There are patients with fibrotic interstitial lung diseases that progress despite initial therapy with a disease course that is very similar to idiopathic pulmonary fibrosis. Emerging data is showing us that antifibrotic treatment with nintedanib or pirfenidone can slow the decline in lung function, very similar to idiopathic pulmonary fibrosis. The safety profile of both drugs, pirfenidone and nintedanib, is similar in chronic fibrosing interstitial lung disease to idiopathic pulmonary fibrosis. Again, understand where your patient's coming from. Understand that this process is continuing to happen. The inflammation leading to the mesenchymal transition to fibrosis. Understand all of that and then decide where you're going to intervene. Because I think that's important because that's going to lead to better overall patient outcomes, as you can see in the data that was just displayed in this lecture. Thanks for joining us today. I really appreciate you guys being here, and I'll see you next time.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer View Institute for Medical Education.